Good afternoon, everyone. Welcome to the Forum on the Hill. Thank you so much for being with us today. For those of you who don't know me, I'm Mary Angela Saavedra. I'm the director of the Center on the Hill. And we're very pleased to welcome our guests today who are going to be talking about a very important topic that a lot of people have asked me about in the last 3 years since I've been the director. So I'm very, very happy to have this conversation today. So I'd like to give you a brief introduction of our guests today. First of all, we have Kathleen Barron, who is a fellow in the American College of Healthcare Executives. She received her MBA from Temple University and has worked in administrative capacity for over 40 years at Episcopal Hospital, which is located in the heart of the Kensington community. We also are welcoming L.J. Rasi, a licensed social worker who has received his MSW from Temple University. He has worked at Temple University Hospital, Episcopal Campus for 20 years, serving the Kensington area and in a variety of positions. And also we're excited to welcome Danny Rivera. Danny Rivera grew up in Brooklyn, New York, and attended the Metropolitan College of New York, where he obtained a Bachelor in Professional Services in Counseling and Development. He then attended St. Joseph's University in Philadelphia and obtained a Master's in Criminal Justice Administration, completed in 2013. He's currently attending Temple University, pursuing a Master's in Education with a concentration in Psychology, with a completion date hopefully 1/2023. Right. Grad education is hard work. But welcome. Thank you all so much for taking your time to be with us today. We will definitely be having a conversation after they present, so start thinking of things you'd like to ask. And if we run a little bit over the 1:30 time and you need to leave, feel free to get up and go. But for the most part, I hope we'll be able to have a nice conversation. So without further ado, welcome. Thank you so much.
Thank you. Good afternoon, and thank you all for coming. What we wanted to do today is talk a little bit about the opioid epidemic and the effect it has on the community, talk a little bit about the trends that we're seeing, and also some services that are available to people. So the first thing up here is that urban areas are particularly susceptible. And we wanted to focus on Kensington for two reasons. We all have experience in that neighborhood. And secondly, because Kensington is known as the epicenter of the opioid crisis in the city of Philadelphia. So how did this opioid crisis or opioid epidemic even get started? And unfortunately, I think the pharmaceutical companies played a great part in this. In the 1990s, when they developed opioids, they marketed it to physicians and told physicians that people would not become addicted to that. And we found out that, over the years that that is not true. And in fact, there's such a large addiction that in 2017, the Department of Health and Human Services declared the opioid crisis a public emergency. So where exactly is Kensington? Let me see. If you can see this little arrow here, Kensington is located in North Philadelphia. Sometimes people refer to it as the lower northeast Philadelphia. Broadly, people sometimes include the Port Richmond section and also the Fair Hill section of Philadelphia. So you can see some of the rankings. In Kensington, the health outcomes are ranked 46 out of 46 sections of Philadelphia, so the lowest in the city. The health risk factors are also the lowest in the city, and the median household income in the Kensington area is just a little over $24,000. Originally, the Kensington area was what you would call a blue-collar area, and there were many factories in the neighborhoods. But if you would drive through Kensington today, you would see really abandoned factories, a lot of vacant lots, and a lot of really long row homes, two-story row homes. So some of Kensington's demographics, just to get an idea of what's going on in Kensington. The male life expectancy is over 8 years less than the Philadelphia average. The female life expectancy is almost 8 years less. 45% of the families and 60% of the children are below poverty level. We talked about the median household income. The unemployment rate is at 27% versus the US average currently at 3.9%. So there's the highest unemployment and the lowest educational level in Philadelphia, which probably about a third of the people in Kensington do not have a high school education. Some of the crime statistics, if you are like me and you look at the news when you get up in the morning, you're always hearing about the gunshots in the Kensington section of Philadelphia. So in Kensington, violent crimes are 205 per 10,000 people versus 96 in the city of Philadelphia. 203 injury deaths per 10,000 people versus the city average of 69, and 8.3 homicides versus the city average of 1.7. So it's no surprise that Kensington's health outcomes are much poorer than in other areas of the city. They have a 16.8% uninsured rate, and so what that leads to is that they don't go and seek health care until it absolutely becomes an emergency and they need to. The teen birth rate is almost double that of the rest of the city. So I wanted to talk a little bit about the physical environment of Kensington. You probably all heard that there were encampments in Kensington. These were there for years, and they were under the railroad overpasses. So there were 4 large encampments, one by the railroads, one under Kensington Avenue, one under one under Frankfurt Avenue, and one under Emerald Street. And this really does not do justice, this picture, to the extent of the people that were out, camped out, and lived on the streets. And this is a little bit better of a picture, but still doesn't really give you an idea of the magnitude of it. As you would walk down Kensington Avenue, people were openly buying and selling drugs. They weren't even behind a vacant store or anything. It was right on the street. People would shoot up on the street. You would find people lying in front of the storefronts. So businesses suffered because of this, because nobody's going to go into those stores if in fact they have to step over people to get there. There's trash everywhere, and not maybe the kind of trash you think of where you walk out of your house and I live in the city, somebody threw their Dunkin' Donuts coffee cup in front of your house. The trash was more, people lived here, so they had shopping carts full of their possessions, their clothes. They had chairs, sofas, mattresses, rugs, blankets, anything that you could think of that they could hold on to, they would keep and have there. The only thing they didn't have were any kind of bathrooms. So what did people do? They went to the bathroom right in the street. So that led this to being one of the reasons that the city also declared this the area a public health issue. So I wanted to touch a little bit before I turn it over to LJ on the quality of life issues in the community. I mentioned that I had worked at Episcopal, and for years Episcopal sort of hosted community groups to talk about the issues there. And representatives from the mayor's office would come, city council people in the area would attend, the police would come, and various people from the community would come. And they would come on a regular basis and to sort of give you the ideas of how the community felt. I think they were angry and they were very frustrated. They felt that the encampments had been there for years, and I should say that the city did clean those encampments up probably in 2018. It took them a good 9 months. They didn't necessarily always have places for people to go. I think that they thought people would want to go into rehab, and a lot of people declined to do that. But they did make an effort and clean up those encampments. But the people in Kensington felt that if those encampments had been in other areas of the city, they would not have been there for years. So they felt like they were the forgotten people. When we talked to people, they talked about the high ratings of shootings that they had there, and that they felt that just by living in that area, they were exposed to trauma every day just by being there. I should say that a large group of the people who live in Kensington are solidly working class, and they're trying to raise their families there. They have children that they want to put in school. They talked about how their parents grew up there, their grandparents grew up there, they wanted to stay there. So you have a group of people that is their home. You have another group of people who live there and don't have the economic resources to move. So they talked about the effect actually that it had on their children, that they did not feel that they could even let their children go out to play. When I talk about the row homes, the homes open right up onto maybe 2 steps and the street. So people talked about the fact that they would find people on their street when they opened the door in the morning, and they would either have to go out the back door or call 911 and have EMT people come. They talked about the fact that they would have to go out and sweep needles off the street before they would let their children go out. About the fact that when it snowed, they actually kept their kids in the house and wouldn't let them play in the snow because they were afraid that as the children were playing in the snow, they would come up with needles and hurt themselves with needles. And actually, needles were all over the place. At Episcopal, I would, when I was there, have the facilities guys go out twice a day and walk around the perimeter of the block just picking up needles. I wanted to touch on schools and churches. There is a school right next to Episcopal, which is Visitation Catholic Church. And it's a church and a school. And over the last several years, they have put up high-rise fences and rolled barbed wire, like you would see in a prison, really to keep people out. I don't see any children going to the school by themselves. Even if they look old enough to walk to school by themselves, they are all accompanied by an adult. Most of the parents drive their children to school. They just stop their car in the middle of Lehigh Avenue, and they get out with their children and walk them into the school. Some other things that I wanted to mention is the city, who was trying to do things, talked about respite care. And we had a building on the Episcopal campus that was not being used. And the city talked to me when I was there about turning it into a respite center. So the idea was that the city would put over $1 million into renovations in the building, and that the people who wanted to come in just to get off the streets could come in for respite. It would not be a place where they would live, but they could get a shower, they could get a change of clothes, they could wash their clothes, they could spend the night, that kind of thing. And there would be social workers there who would talk to them about, are they interested in recovery and how they would get into recovery, but it wasn't really going to be a hard sell. This was just an idea to get people off the street. Right next to that building is right across the street from this school, and right next to a building that I rented to Kencrest, which is for preschool. It's a daycare for preschool. So while I was talking to the city, I called the director of Kencrest up and said, this is what I'm talking to the city about. It is the same block, it is right next door to you, the building. How do you feel about that? I'll make sure that there is a higher fence between the two buildings, but the people will be coming in there. And interestingly, the director said to me, have you walked down B Street lately? There's all kinds of people out on the street. If you can get them in a house, that's better for us. So that sort of gives you the idea of even the people in the community are trying to do anything they can to make sure that people are off the streets. The one area that there's a lot of division on, actually, is safe injection sites. And there is, to my knowledge, there is not yet one in the city of Philadelphia, although I know that Mayor Kenny is in favor of it, as it was former Ed Rendell. And the idea behind that is that you provide a place where people can come in, bring their own drugs with them, and shoot up there. And that there will be health professionals on site where they shoot up. So should they overdose, someone will be there immediately to provide them with emergency care. And the idea with this is, it is just to reduce the number of overdose deaths in the city. I did hear that they have started some in New York. The problem with this is, of course, doing drugs is illegal, and the federal government has always stepped in and said that they would maybe prosecute people. And so that was not obviously the idea of that. The neighborhoods are also not really in favor of this because they feel it will attract more people who are doing drugs into the area, and that they will never get out of the of being a drug site. It will just have future implications. The other thing I didn't want to leave without talking about was really the gentrification of Kensington. So it's been interesting to me over the years to see, amidst what I would consider vacant areas or houses that are actually vacant also, that there is an attempt to gentrify the area. You can see it moving up on 2nd Street or Northern Liberties. You can actually see it maybe a half a block from where these encampments were. They have built what they call Kensington Court. And these are over 300 condos that have gone up on Lehigh Avenue in what used to be a used car lot. And I looked in the paper, and those condos are going for $300,000 to $400,000 a unit. So that in this area is just amazing to me. But it does show that there is some attempt to also bring some gentrification to the area. So I'm going to turn it over to L.J.
Thanks, Kathleen. Just a quick show of hands. How many of you have been to Kensington in the last 2 years? Anyone? 2. Okay. All right. How many of you have never been to Kensington? Okay. It really is just a sight to behold. I live about 10 minutes from here, so my commute into work is about 10 miles. And it's like a completely different land. So it's just really interesting to see. Just going back to some of the statistics of the area, and I'm focusing more on the mental health needs and some of the substance use patterns in that location. But these statistics here come from that same survey and study that Kathleen was referencing. So in Kensington, folks have about a 55% increase in what is rated as poor mental health compared to the overall city. So that one little ward of the 46 has a 55 increase in that statistic. Folks in Kensington are more than twice as likely to be smokers. And then this statistic here, so in this city as a whole, 44.8 out of every 100,000 residents dies from a drug overdose. You can see the rate in Kensington is 152.1. So we see more overdoses in that location of the city than anywhere else in the city, and it's by a significant factor. So the great thing about Kensington is, as Kathleen mentioned, there are plenty of resources there. So these are the different levels of care regarding the substance use treatment. And Kensington is one of the few locations in the city that has all of those levels of care directly housed in it. So the first one would be detox. So detox is a level of care that folks who are actively using drugs and want to stop without getting sick will avail themselves of. It's usually about a 3 to 5 day period where they will wean them from what substances they were using, generally with medications, either comfort medications to make them feel not as sick, or actual medication-assisted treatment, which is instituted to move the patient from using illicit drugs onto a medication that replicates some of the same biological pathways. The next level of care is rehab. So that's what we've classically heard of 28 days or 90-day programs. So there's two specific levels of rehab. There's what we term short-term rehab, and generally that's a commitment of about 4 weeks, about a month. And then long-term rehab, which is generally 3 months, can be extended up to 6 months. There's a lot of research that shows the longer folks are in rehab, the better. So a lot of people will go in initially to a short-term rehab, and if they're doing well and they want to continue, get moved directly into long-term from there. There's all sorts of fancy names and numbers that we attach to these levels of care, but really that's what a rehab is supposed to do. A rehab is supposed to encourage the patient to come off of the substance, give them a lot of coping skills and coping mechanisms to do things other than using drugs to combat stressors, anxieties, maybe unresolved mental health issues. Partial program. So partial program is generally, I like to say it's the rule of fives. So folks going to partial programs are generally going 5 days a week to a program for about 5 hours a day. And where that terminology comes from is a partial hospitalization. So it's like they're in the hospital during the day and then they go home for night, versus being in a rehab where they would reside there. But partial program is next in the list. Then we have intensive outpatient, which is a rule of threes. So intensive outpatient is usually 3 times a week, 3 hours a day that someone would go to treatment. A few of those hours are in a group setting throughout the week. At least one of those hours is going to be an individual session. And in that weekly programming, they would also be meeting with a psychiatrist if needed for medication adjustment. Outpatient is what we would commonly refer to as just meeting with someone once a week, once every 2 weeks, to really go over some of the things that are leading to their substance use and try and resolve those barriers. And then, as Kathleen mentioned, respite programs, she talked about those. But Kensington is unique in that whole list of services exists within that area that Kathleen noted above on the screen. So some treatment considerations. So you might be asking, if there's all this substance use and there's all these treatment services in the same location, why aren't things improving? Why isn't it getting better? And one main thing is there's often a gap between what the services are and getting people to actually engage in those services. So all of those levels of care I mentioned on the last screen are all voluntary. So if the person who's using substances doesn't want that help, they're not going to avail themselves of those services. Same sort of thing once the patient's actually in services. It's nothing that can keep them in that service. So if they decide, day 2 of their 28 days of rehab that they no longer want to be there, they have every right to just walk out the front door. Whereas some of the rules surrounding mental health are a little bit different. There are commitment laws in the state that allow folks to receive treatment against their wishes. Substance use, it's all voluntary. So there are also a lot of social determinants of health. So Kathleen mentioned the income, level of the folks in Kensington. There are a lot of other social determinants of health, or things that really prevent them from actively engaging in treatment. They might not have transportation. They might not have someone who can watch their children if they need that. Years and years ago, the building that Kathleen mentioned is currently a respite center, was a drug and alcohol rehab center for women with their children. So there's very few of those anymore. So they might not have that ability to get into treatment. So there's all these things that are born out of those educational stats, those income stats, those crime stats that really impact the individuals in that area being able to seek help. If you're afraid to go out of your house because of a crime wave, you're not going to be able to get to those sites. Other things that are sort of to note between this discrepancy between the services available and the services actually used are that all those constituencies that Kathleen mentioned, the residents, the individuals in the encampments, the police, everyone comes at that issue from a very different angle. So the police want the folks off of the street. The residents want them actively engaged in treatment and no longer being homeless. The homeless folks might have different needs that they're thinking about wanting. And there's not a real good convergence of all of those different populations thinking, this is the way that the neighborhood can get better. This is the way individuals can improve. There are some novel treatments being approached in Kensington. The Respite Center is one of them, and Danny's going to touch on a few more a little bit later. There's also a new policing model that recently came to the Kensington area within the last year and a half, I would say, is when it was instituted. So this little sliver of the city makes up a disproportionate share of the crime. So much so that the police were looking at it and they decided to make a new precinct just for, I think it's like a 12-block corridor. It's a very small, one of the smallest precincts there is. That's how much volume of crime there was in that area, and that's how much need there was. So we're hopeful that the new policing model might help, but that is also sometimes hampered by some of the city initiatives in terms of prosecution as well. So it's not as clean a model as it would have been a few years ago. And then the main thing to consider is that the usage patterns change very rapidly and quickly. And those of us in healthcare often find us fighting yesterday's battle or last year's battle. So by the time everyone in this room had heard of the opioid epidemic, we were actually seeing less of that in the patients coming in. They had moved on to cheaper, more potent substances. So right now, we're seeing an increase in methamphetamine use, and we've seen it now for a couple of years. I would imagine in the next year or two, there will be a lot of public information and a lot of news broadcasts about the methamphetamine crisis or epidemic. But the drug usage patterns are constantly evolving. As Kathleen said, it arose from prescription medications into what we're seeing now. So it's really something that those folks in the helping industry have to really be on top of and listen to what our patients are telling us as they come in, because we're constantly learning new things that they're pairing drugs with, new ways of using them, and each one has its own little dynamic in terms of how the patient presents and how the treatment has to be given. So I'm going to turn this over to Danny. Thank you.
Thank you very much. Thank you very much. Okay, so, good afternoon, everyone. Can you hear me now? Okay, so I am going to talk about what is happening. Why do we have all these people in these tents? What's driving this population to lose control and use substances to this level? Kensington is considered the largest open-air narcotic market on the East. And that means people from New Jersey, people from Los Angeles, California, believe it or not, will travel to Kensington to see what's going on and why they consider it to be the best. The high rate of overdose deaths is what really brought our department here to Temple to work closely with the physicians and nurses to find ways of providing treatment for those addicted to opioids. 80% involve opioid use. Now, does anybody here know anybody who's addicted to opioids or had some major experience with opioids? Oh, well, that's a good thing. Very good thing. This is what's really driving this population. In Kensington and in the tents, they are all addicted to opioids. Now, opioids has been, as Kathleen and L.J. has stated, it was a prescription drug that was used for pain. And athletes, anybody who was feeling some pain behind their physical abilities, were given opioids. And they still do it now, but with regulation, extreme high regulations now, to the point that some physicians are unwilling to prescribe it and find other medications other than that. But that's the driving force of this pandemic that we're dealing with. 64,000 people died of an opiate overdose from 2016 to 2017. And that has raised the red flag across the board, and that's where we had all pharmaceutical companies being investigated about pushing, they call it, opioids. Which button is? Right, here we go. What trends, what's really driving? The primary drug that we see every day, and the staff that work at Temple who are conducting assessments on a daily basis for those walking into our emergency departments, reaching out for assistance because they had enough, is heroin. Heroin is an opioid that is cheaper than the prescriptions that were given by physicians for any physical pain. So somebody who's addicted to opioids, let's say, got hurt playing football. They go to their physician, they can't, the pain is too much, they give them opioids. They start taking it, they feel better, they don't feel the pain. After a while, they continue to take it like vitamins. Their bodies become immune to it, and they become dependent on it. So when they don't take it, they feel physical pain behind not taking it. So they'll take another one, they'll feel better. So what happens, it's so expensive, the prescription brand, that they have to find a way to get a cheaper opioid. And this is where heroin comes in. People go out and buy $5 a bag, opposed to $20, $30 a pill. So this is what happens, the transition from a prescription into a illegally used drugs in the market is heroin. So that is the primary right now. Anybody who walks into ED, opioid use, heroin use. Then came fentanyl. Anybody ever heard of fentanyl? Okay. Fentanyl was the driving force that killed 64,000 people. Once fentanyl hit the market, they were mixing it with the actual heroin that was being sold in the street, which made it 100% more potent than it should be. So when it first hit, I would say 2016-ish, I was working as a director of a substance abuse program. And they would have certain sections in Kensington, in Philadelphia, where they would actually sell the drugs. Dealers would sell these drugs to the population. One night on a Sunday, I received a call as director saying 26 people were rushed to the ED within the same time frame because the bundle that they sold in that area had so much fentanyl that anybody who used it wind up laying out on the floor, and the police ambulance, or they were just taking people left and right. So 26 people on a Sunday night at the same time were transported, and we lost 3 bodies, 3 people that day. The others were revised by Narcan, and I'll get to that in a second. Now, fentanyl is the killer, because people were using heroin prior to fentanyl, but the overdose level was very low. People knew how to maintain it. They knew how much their bodies could handle. But when they started to mix fentanyl in it, they didn't know what they were getting. So they would just use the same amount they would normally use as they were doing with heroin, and then their hearts will stop, their organs will shut down, and people who were actually using next to these individuals would run away thinking they would be prosecuted if the police came, and the person would actually die by the time somebody got to the person. So it was fentanyl that really triggered this whole opioid epidemic and the massive amount of people we lost over the years. And now, fentanyl is being sold by itself. No more mixing. People know about fentanyl. Go over there to the corner and you can buy a bag of fentanyl by itself, and they know it. But it's a little less potent, and they feel the same effects, but it's at least expensive too, a little more or less expensive. So now people will just come in, I use fentanyl. You know, so it's an addictive mentality, and this is what happens when somebody's addicted to whatever substance. They will do whatever they can to get that high. Now, alcohol, I don't want you guys to forget, alcohol, cocaine, and benzos are still on the list. We still see them every day, but they're not as prevalent as fentanyl and heroin. So they just come as part of coffee and toast. Coffee is the heroin to them. Toast, okay, well, we'll take some toast. We'll take some benzos here. We'll take some of this. But the driving force is the opiate epidemic. That is powerful, and it's killing people to this day. The overdose rate, I mean, they show that it dropped a little, but it's not that impressive to me. It's still up there. It's a killer. Now, that picture there is crystal meth, and this is what L.J. was talking about earlier. Meth is taking over. We see it, and the reason why is because there's different highs from heroin and crystal meth. So they like balance themselves out by using each every once in a while. But what they're doing now is they're mixing fentanyl with all drugs. There are people who come in and say, I just use cocaine, Dan. And I say, okay, so why is it that you have fentanyl in your system? Because they mixed it with the cocaine. Now they're mixing it with the meth. They're mixing it with everything. Back in the 80s, when people bought marijuana, they got marijuana. If people bought, cocaine, it was the form of cocaine that was sold. Nowadays, you get marijuana, it's synthetic, it's sprayed, it even sprays fentanyl on. There's a spray with fentanyl. They spray it on there. They put PCP on it. Cocaine, they mix fentanyl. You don't know what you're going to get anymore. This is the dangerous part about it. And it's recreational use. You know, we're thinking about our kids, our future generation. And they are I've never seen anything like it. I've worked in the 80s, and they were pretty much a certain level age of this kind of addiction to heroin. Now they're 20, 21, sleeping in tents, prostituting in the corner of Kensington. I mean, this is how powerful this drug has taken over. And, 21-year-old, out there in the streets living in tents, I mean, this is a very, very powerful drug that's taken over. So I got a picture here, and what is fentanyl? Fentanyl is actually a painkiller. It's a painkiller used by physicians in the EDs and for operations and things to make you feel less, pain. It's an anesthesia. They use it, with other stuff. But now they're using it because the effects are very powerful. And there's certain levels too. There's fentanyl and carfentanil. They animal tranquilizers. They use them for horses, elephants. Carfentanil is used for elephants. A little tab like this, with somebody whose tolerance level is not even close to understanding it, will kill them immediately. And this is what they're mixing drugs nowadays with. And this is why people are overdosing so much. So yeah, heroin is number 1, fentanyl is number 2, and carfentanil is number 3, because it's a killer. So that's pretty much how it functions. Now, like I stated, alcohol, cocaine, and benzos has taken a back seat because the amount of people who died on opiates was frontline page. It was front page. It had to take over. We had to deal with this issue. We got to deal with this. Young kids, 21, 22, are becoming addicted to this. They're sleeping in the streets. Their parents are looking for them. They can't find them. Some are dead. It's crazy. So it took a back seat. There's many people who are addicted to alcohol, major, and are struggling with it, but they don't make too much noise about it because they have something of a primary right now that they have to handle, and that's the opiate. Okay, so programs addressing this. So yeah, so you're probably going to hear it on the news and all over the place. They are trying to address this on all angles. It has to be addressed. So nonprofit and government's responses to it are basically finding safe housing where people can actually go from the street into safe housing and have some kind of case management services. Things, substance abuse counseling, whatever they need to get them back into a normal life. Because right now they are not living a normal life. Food, Medicare, because of the amount of drugs they're using, especially opiates. When they started using opiates, it was pill. Then they snorted. Then they injected. You see, injecting, it goes into your system a lot quicker. And you feel the effects faster. So somebody who's addicted to a drug will not want to wait for the feeling. They want it as fast as possible. So when they first introduce, they usually don't inject it, they snort it, they enjoy whatever effects it has or euphoria has. But after a while, it takes too long, so they start to inject and it hits the bloodstream immediately and the effects are right there. So that's where that comes. Now, because they're not responsible individuals, they start to share needles. That's where the medical issues start coming in. They start to get blisters. It just gets worse, worse, and worse. And they wind up in our ER, 23 years old, with blisters all over the place, veins half dead. You can't even find a vein. You can't even use that vein because it collapsed. So it's one of those things that if you don't catch it, it just keeps going and going and going. Harm reduction programs is one way that they're trying to solve this issue. And as Kathleen stated earlier, the injection sites, there's always going to be a pros and cons. And the pro is to, save lives, have case management services, and when they walk in and they have use their drugs, try to encourage them into treatment from that actual site as well. To target it in some way, and also make the community a lot safer by removing them from the community to do what they need to do somewhere where it's secure. And, not needles all over the place, as you were stating earlier. And the other one is Narcan. Have anybody heard of Narcan? Okay, so I just brought this sample. It's naloxone. This is the reverser. So let's say somebody takes opiates. It attacks the receptors of the body. So it just goes like this. and then that person starts feeling that high. You usually start seeing them nod, you know, just, you think that they're gonna hit the floor, but for some very strange reason, they pretty much balance. They don't fall, but they look like they're gonna fall. And this, what it does is reverse an overdose if you get there on time. Now, I reversed 6 overdoses in my time frame working in the field in an outpatient setting up in Bristol. And each time, you don't know what the outcome is gonna be, and it's nerve-wracking. But it's the best way to save somebody's life. So this was developed back in '80. Well, way back than that, but it was being utilized for the opiate reversal prior. This was initially 2 milligrams of a spray, naloxone, that you just like if you're taking one of those, you know, to clear your nasals. But the 2 milligrams did not work when they started to mix fentanyl in. They were seeing like, wait a second, it's no longer working. What happened here? So the fentanyl and the heroin made it more powerful, so now they make it 4 milligrams. So they had to put 2 more milligrams in here, and this is what they use to reverse an overdose. This is what your EMTs use. This is what I use. I carry it in my bag. This is what all clinical professionals use. You know, this is the way. At one point, we had to use a needle, and not everybody was comfortable with that, so they just found a way to make it even easier. And this is what they call a miracle spray. If somebody can have a seizure right here, right now, oh God, please don't. And I could give them Narcan thinking their person overdosed or whatever, and if it's not, if there's no opiates in the system, nothing will happen. There's no side effects if I use it on somebody who's not using opiates. But it's better safe than sorry. So, yeah, this is the miracle pill spray that they developed, and it's reversed many overdoses over the years. Diversion program is police pick up a person who's using and is acting like, you know, disorderly, remove them from the community, bring them to us, and do an assessment and get them into treatment. Instead of taking that individual and putting them in prison, and after 2 weeks releasing them, and nothing's been solved. So it's a good way to try to address the issue. And we work closely with them. Actually, I just got a call from them when before we started this. Mobile outreach programs, they have mobile teams now all over Kensington who actually go out with professionals, certified recovery specialists, counselors, trained counselors, police, you know, regular clothes or whatever, just to talk to individuals who are sleeping in the street in tents to see if they can get them into treatment. If they agree, they put them in a van, they take them and get them into treatment. So they're mobile outreach teams, which has been also an success. Immediate treatment access. Okay, so now if a person says, okay, Dan, I want treatment, and there's no beds available, and there's no treatment site to send them to, and they're not gonna come back. You can't tell them, come back at 9 o'clock the next morning, we'll find you a place. They're not that responsible. They are in it. You gotta get them to treatment when they're there and ready. And that's what we have been doing successfully at Temple with the team, and we're very proud of the outcome. So yeah, let me see what else I got here. So that being said, if I didn't answer everything, that's basically what we're doing right now.
I have a question.
Sure.
Is this a good time?
Yeah, for me?
For anybody?
Oh, yeah,
But
yeah.
for you.
Okay.
There are problems on so many levels that one question won't do it. But if you had more resources for Kensington, this is a nationwide problem, what are the most effective things, resources, help, would you call for to attack the problem? Because if you have people coming from Los Angeles, they're outsiders and causing problems. What 3 things would the 3 of you decide would be the best way to attack the problem and maybe solve some of the problems in Kensington.
Would you like?
You go.
Okay, yeah, so one of the main things that I can definitely tell you that is problematic for us to treat those who are suffering right now, which is the bulk of people sleeping in Kensington, is housing also. The housing shortage is huge. And here's why I say that. Treatment has been cut down to 30 days. All right? The average person could get 28 to 30 days. And in 1981, you had 2-year programs, and they focused on phases of somebody's life: treatment, individual groups and therapy, school, placement, save money, move out to your own apartment. They don't have that anymore. In 30 days, you got to do all these things that you need to change in your life. So one thing I notice is they can go to treatment for 30 days and be successful because they in a treatment site that's secure. No drugs are coming in there. It's when you leave that's going to be the challenge. So if you go back to the Kensington area after treatment, you're more prone to fail than if you go to some other housing location that's going to support your recovery and continue that journey until years from now that you're strong and you're able to get everything together in your life. But housing has been a huge issue for us. Huge.
I would agree with Dan. If there's one thing we could add, it would be housing. And there's actually a model, it's called the Housing First. And the results from that model have been truly impressive. So what that model does is it takes funds that used to be used towards rehab, towards hospitalizations from the medical world, and it drives them directly into paying rent for the person to live somewhere. And their outcomes are extraordinary. It's obviously up front, it's a costly program, but if you look at it longitudinally, it's actually less expensive than our current model. And what Dan was mentioning, we in the business say people, places, things. So it's really hard, as Danny mentioned, if you're away from the drugs for 30 days, and then we put you right back onto the corner where you used to use, where your friends are using, where your loved ones are using in the house. So that's a difficult proposition. Kathleen, do you have anything? Okay. And I saw another hand.
How about best practice? How about other countries? I don't hear about Kensington in the news, but how about around the world? Do they have the same kind of problem? I imagine they do, maybe.
So I think that they do, and I also think that's where you get the idea of safe injection sites. That has been utilized in many other countries with very much success in cutting down the number of drug overdose deaths because there are people right there. It's been hard to get any traction for that kind of treatment in the United States because, as I said before, the federal government says it's illegal to use drugs, and people don't want to be putting themselves in a position where somebody might come and arrest them, even though the city in Philadelphia has pretty much said if they know that's going on, they won't do anything about it. People are still reluctant to do that, and I think that's why nothing has occurred in Philadelphia, although the 2 sites in New York, the feds haven't touched them at all, so I think you might start seeing changes there.
Yeah, talking about the federal government, in fact, I think it was just in the newspaper recently, the federal government seems to be wavering a little bit. The Department of Justice seems to be softening its position. When somebody like myself who doesn't know a whole lot about this, and I see the feds say one thing, the city says another thing, the doctors say another thing, it sounds like there's just discord about what should be happening.
I think there is, and I also think that as time goes by and you're not making progress or you're seeing that nothing works, when I was talking with the people in the city, they were willing to pretty much try anything. And I know that people in the city actually went and visited safe injection sites in other countries to see how it worked. And so I think you're going to see people trying, okay, what else can we try that's innovative, that's maybe thinking a little bit outside the box, because where we are now is not working.
Yes.
You talked about how many different types of products over a span of years have been available. Where do they all come from, and is the supply problem identified clearly?
The manufacturing?
Yeah, manufacturing
Okay.
and
So-
mobilizing.
Right, so basically, the opiate epidemic, as you all know, was manufactured through, pharmaceutical companies. I mean, they developed that for painkillers, and, they introduced it to individuals in society, and that's how that started. However, the large majority of cocaine comes from Colombia. That's the dominating market for cocaine, that comes from Colombia. Opiates, heroin comes from Afghanistan. I mean, with the opiate poppy seeds, it's still getting through customs. I mean, there is a huge responsibility of our government to protect the borders from drugs coming into our country. But as you and I know, we were born with them coming in, and here we are. I'm 56, and they still coming in. So I don't think. And this is what I try to convey when I do talk. I don't think, and I hope, but I don't think that they will get rid of drugs or any kind of substances in our country. And I just personally think it's a big money maker for many people, and people who have control of what comes in and what doesn't come in. So that being said, I think this is an individual battle. I talk to individuals and I say, do you want to stop using? Yes. So you're going to have to battle this, and I'll give you some skills and tools to do it yourself. Individually, you can do it right now, but trying to get rid of drugs from the market is quite close to impossible the way this has been going for so many years. So we're addressing it on the individual level. I do. And I've seen many successes. And remember, recovery from substances, and any major substances, happen. And they're successful stories, like myself. And it's not put out there in society because of the stigma. People will hide their past experience because they don't want to be judged. There's many people, politicians, many people who say, I don't drink. Why they don't drink? Because they're allergic to it, they say. But we know they probably had a struggle with it. People succeed in recovery. What we do is we see the bad side to it, but we never see the success. The success is hidden because of stigma. We trying to break that stigma too, and with doctors, physicians, nurses, how they interact with people who struggle with substances, to change that. Then maybe one day people will say, I succeeded, I succeeded, I succeeded, and we'll see that the money that's being pumped in and all the efforts that we're putting in are actually working. We don't know the success that's out there. I know a few people who are very powerful with a background in that area. And they don't share it because, society is not quite ready for it yet. Yes.
A lot of the discussion today has been about what happens when the person has taken the drugs and how we're going to get them off it and get their life back together. But the genesis of the problem, if you're looking at the genesis of the problem, how would you rank like mental health versus poverty versus education?
So I'll start and then we'll pass that one around, because that's the key issue, right? And I think a lot of it's born out of those first few slides that Kathleen alluded to. So if you're born into poverty, are your educational experiences going to be the same? No. Are your opportunities going to be the same? No. Are your friend circles going to be the same? No. So there's all sort of play off of each other, and it's really, really tough. Kathleen mentioned that dichotomy between what the neighborhood in Kensington used to be and what it is currently. And there are those two factions living door to door in row homes that are as close as Kathleen and I are sitting. And it's really difficult. But I think that's the start of the problem, and that's the crux of it. I'll pass it on to Kathleen now.
particularly interested in the mental health part of this, like,
Yeah.
poverty, I can see that's probably a big, and just sort of like the ranking of it, like, is that, like,
If I could, L.J.
Yeah.
Okay, so we, I don't know what the average, but we see a high level, very large amount of patients who come in with primary mental health, secondary substance.
Yeah, yeah. So it's 75, 80%.
It's about 80% of people who come in with mental health issues have an underlying substance abuse problem, and they really start taking the substances in order to cope with their mental health issues.
So,
that is a big
in the cases you
part.
see though, are those particular people 20% of the cases? Or, in other words, there's a lot of people taking drugs that don't have mental health issues either. So just in terms of for me to try to break down how big this pie is and where the slivers are. Because sometimes when I talk about it, people go, well, it's mental, you gotta solve the mental health problem. That's what you gotta solve. Well, is that 10% of the problem, or is that it's 90% of the problem for continued drug use? And how they get started, I don't know.
So I think it's fairly, is this on? I think it's a fairly high percentage of people who have mental health issues and substance abuse. I think it's in the 75 to 80% range.
And you talked about there's been a lot of changes over the years in how we deal with mental health. And I guess I would think that the solutions to the mental health issue and the solutions to the drug issue, they're going hand in hand, right?
They are.
They're codependent.
Right.
Yeah, as are the symptomatology. As Kathleen said, about 80% of our mental health patients have a comorbid substance use problem. Going back to that mental health and sort of the genesis of this issue, so a lot of research has been done on mental health, and is it genetic, is it environmental, and almost all the research points to what's called like a two-factor hypothesis, that the folks that have become afflicted with mental health issues, they have some genetic predisposal, but it's an environmental trigger that sets it off. And living in that neighborhood, seeing that crime, having those experiences, are all the things that could trigger that underlying predisposition. So there's one of the patients that I've worked with pretty closely. She saw her uncle murdered in front of her at age 11. Now, how are you supposed to combat that, right? And the uncle had just come home from prison that day. So it bakes into all of those experiences. And she was living with 7 siblings in a 2-bedroom house with no working parent. So you look at all of that, and the chance that that's going to be a successful foray into adulthood is slim. So it started her mental health issue. She did exactly what Kathleen said. She didn't go for treatment. She tried to soothe it with substances, and then you wound up right where you'd expect.
Thank you.
Yeah, Mary Angela.
So, I, without sharing too much, have had kind of a lot of medical issues throughout my life. And at what point do we start to like hold the physicians responsible? Because I know that I myself am very educated, and so I try very hard to push back, but every doctor in my entire life has been like, take this, you want to do this. And I'm like, but there has to be another way. You're telling me I need to, take this. I mean, at one point I was literally handed benzos, and they were like, you should be on this is what you should be doing. And I'm like, there has to be another way. But I know that if I hadn't said that, I probably would have gone home with it. It makes me think, like, at some point as a society, like, when do we start to hold physicians accountable? Or,
So I think you see that changing now.
Yeah.
I had the same experience. I had a bike accident, and I went to several physicians, and each one said, let me write you a prescription for an opioid. And I said, no, I'm not in that much pain. I can handle this with Tylenol. If I'd been somebody else, I probably would have taken the prescription and gone and filled it. But I think as the pharmaceutical companies have been held responsible, I think that people have to now There are people that look at physicians' individual prescribing histories and call out attention to people that have high prescription rates for certain drugs. I know when they come into the emergency room now, physicians are attuned to people who are really in there seeking drugs and don't write them prescriptions, whereas maybe in the past they wrote a prescription so that they could go on with to the next patient. I think you see that changing, and that's really probably been in the last maybe 10 years as the opioid crisis has come to the forefront, and the reason why.
Yeah, so I think individuals are now taking more responsibility for what they take or what they don't take, and doing the research for themselves more so now than in the past. And believe me, my parents were one too. If you wore a white coat, you had all the answers. But not anymore. People are now starting to look into, my mother's calling me on a daily basis, so this side effect here, should I be, so people are really taking the front row on this one, so.
And now they have added some safeguards too. So when physicians order some of these different class of medications, there's actually a statewide registry that they have to go through. They have to make sure that the patient didn't see Danny and get the same thing yesterday. So they're combating it a couple different ways.
So what about folks who have gotten through rehab, and you mentioned the lofty goal of better housing, more housing, and let's assume for a second that we could get there. Don't those folks also need an awful lot of training? They're going to need a skill to get back into the world. Are there programs available for them to do that?
Yeah, and that's where that length of treatment becomes so pivotal. So Danny mentioned, in the 80s it was 2 years, then we shrunk it down to 28 days, and then research said, no, it really should be 90 days. So during that course of treatment, they are often getting vocational rehab services to help them find a job. They're getting education. They're getting, like I said, work with coping skills. So if I'm having a stressful day, my turn used to be to take a drink. Now my turn's going to be to exercise or come up with whatever works for them. But the problem is making sure that that treatment is long enough to engage just those things that you said. So that's really the housing. I think the question was asked, like, what would be the one thing you would institute? And housing would definitely be the one, but there's got to be other things adjunctive to it, just like you mentioned.
Okay.
Kathleen, you?
I was just going to say that the pull of this addiction is amazing. I have friends who have picked their son up after 12 months in a rehab center, and driving home, the son has said to them, Mom, it's not if I relapse, it's just going to be a question of when I relapse. And they do have a harder time, I think, getting back in the workforce, especially if they maybe miss a day or 2 days or something like that. If they have a little relapse, then they've lost their job. And it's very hard for them to hold down a job, which I think just contributes to the issue.
Yep. Ongoing support, you have Alcoholics Anonymous, which is a driving force for those who struggle with alcohol. They develop a social system. They're able to go out together. They're all able to enjoy things sober. Our society, as you probably know, and a lot of events involve alcohol, drugs, partying, this, that. So in adjusting to that type of lifestyle where you don't use drugs or alcohol, where do you go? So AA, NA, and things of that nature are very encouraged when somebody completes treatment, so they can develop a new social support system of people who don't use, and be able to actually go to events with people who don't use, and learn how to live without using. I mean, there's people that can't even go to the dance floor unless they have something to use so they can dance. I mean, that's how insecure some of these individuals are. They have to be taught these little things, and they have to adjust, and it's not comfortable. So, yeah, support is huge after treatment, yeah.
And one other thing is, from the institutional point of view, Kathleen, we've spent hours thinking about these things over the years, and that is that there's a kind of systematic targeted use of funds, whether it's from non-government institutions or the government. You just imagine, for example, that on the basis of need, emergency rooms kind of come first, but there are institutions that have 100 programs, and so it's a matter of prioritizing them. And it's a practical matter. People that come in and are not able to do their part in taking care of themselves are not the most easily treated individuals. They and their family, they're very difficult, and they are not inclined to take advice and all the things that you've told us about. But institutional funding is a major problem, and some people are good at it, but others have trouble. And some institutions just lack the resources.
Yeah, and it's, again, the stigma comes in there too, because it's not like a high-profile service, you know, it's not like a cancer center or a transplant unit, right? You're dealing with substance use, you're dealing with mental health, which sometimes gets put on the back burner, funding-wise, as well as just from a public view.
Yeah, but you're actually correct. I mean, you know, the institutions, they do have institutions, because there are some individuals that just will not be able to live in society as we would like to teach them to do so. I mean, and that's on the mental health level too. And we have institutions that actually, they can live at it. They can live there. They have staff members, and you know, that really help them live, because they can't live in society. But they cut the funding, like Norristown State Prison, Norristown State, they cut that, and they wind up in the prison system. So now we have a prison system that they say, this is a mental health prison, you know. Everybody that was released from state prison from Norristown is in prison. So, yeah, institutions are needed to address some of the issues of the individuals we can't help.
And to your point, if they now get a prison record in addition, trying to rebuild their life becomes that much harder.
Yep.
I want to thank you all so very much for being with us today, and thank you all for your time. I learned a lot of information from this, so I want to thank you all very much for taking the time to speak with us.
Thank you.